everybody. Welcome back to another episode of the Core Consults RX podcast. Cole and I flying solo again today. Just cannot get the timing right with old AJ.
No more vacation though?
No, this one was actually my fault. I even checked the text messages to make sure I was in the wrong. Because I told him we were recording Thursday because our days.
That's what we had.
Yeah. So I was like, all right, never mind. That's
We're mixing it up.
Mixing it up.
We're keeping him on his toes.
So yeah, when I tell him the wrong date, it's probably my fault. So he just shows up at my house on Thursday.
Right.
But yeah, so for those of you watching the video, that's why we're not using our fancy camera setup. It's just the one ugly angle of Cole and myself. So no computer sharing, sharing my screens. That's unfortunate.
AJ's vital to our process.
He really is. Nobody tell him that, but yeah.
He doesn't listen. It's okay.
It's true. So we're doing an episode today that's a little bit different. We're going to kind of talk through some of the new drug approvals because it's January, at least when we're recording, it's January 24th, and we've already had a few pretty big drug approvals this year.
Yeah, we're talking 2023 drug approvals because about a year ago this time we talked about drug approvals from the previous year, which you would think was what we were going to do, was to go over 2022 and see what was approved in this past year as like a reminisce on what's happening. Big summary.
But we realized that if you do it in January and just talk about 2023, there's so much less
to talk about.
To worry about. Yeah. So we were like, oh, that's perfect.
But it's perfect because there have been 3 interesting drugs approved, 2 of them novel, like what FDA would consider novel drugs. One of them was just approved this morning that we're recording. So
I think it was actually, or
the press
release, but I think it was officially approved because I thought the same thing. I was like, this is the closest we've ever gotten, but it was the 20th.
The 20th.
Yeah, we were late.
So that was
24 or 4
Friday.
days late. It's basically old news.
Well,
so we'll just stop the recording.
The press release that I saw came out.
Me as well. I read it literally riding from the parking lot to the hospital this morning to go to work. So,
we're going to talk about them. We're going to see if any of them matter.
Yeah, we'll see.
Do any of them matter? That's the question. Are they practice changing? We'll find out.
Yeah, I'm not super.
We'll see if it's
excited.
1 out of 3, 2 out of 3, 3 out of 3, or none.
None. So. Yeah, and then we'll have to wait till February to see what
They're
comes
all
out.
terrible.
At the end of episode. So what did we say we're going to start off with? I already forgot.
I think the new SGLT2 inhibitor.
So you guys know we are big fans of most of the SGLT2 inhibitors, but we got a new one coming out.
We do.
Bexagliflozin, under the brand name Brenzavvy, I believe. Brenzavvy. I like 2 V's. I do like that.
Why are 2 V's not a W?
Well, but there's a space in between the top.
Why isn't it double V?
That's a good point. Maybe because it was originally in cursive and they just couldn't tell.
That's a good point. But when I do my uppercase W, it's more like 2 V's. Like 2 U's. Anyways,
but I do like the 2 V's and Brenzavvy. It's very
savvy,
very cool. Yeah,
Brenzavvy.
So this is an SGLT2 inhibitor, like Cole said. Believe it or not, actually, humans were not the first species to have this approved for. In December, it was approved in felines.
I saw that.
So if your cat has diabetes, you can give him an SGLT2 inhibitor. I believe that's the first one for, at least for felines. So somebody correct me if I'm wrong on that. But the definitely interesting there. And then we get approval a month later. We tested it on the cats, see how it goes.
I hear a lot about cat diabetes. It's like the unspoken epidemic is cat diabetes.
The second leading cause of feline-related death. I'm just kidding. I don't think that's true.
It probably is.
Maybe. I mean,
my cat is extremely overweight.
I feel like if you're eating rodents and things like that, it seems like a low carb.
My cat does not eat rodents.
No, you don't feed him rodents.
My cat eats dry and wet.
So that's why. So
cat food.
Diabetes only exists.
As much food as she can possibly eat.
Only exists in domesticated cats because we're feeding them nonsense.
Yeah, you don't see lions out there with diabetes.
You never see a lion with diabetes, at least not that I've seen. And I've spent a lot of time around lions. All right, anyways, enough of that. So this medication got approved, and we have another option for treating diabetes. It's only approved in patients with diabetes at this point. It's obviously brand new. What were your first thoughts?
Yeah, I mean, my first thoughts were, I guess, as far as diabetes goes, just strictly if we're talking sugar and A1C reduction, similar to the others, which is relatively modest. We don't really look at SGLT2s as being like huge A1C reducers and whatnot. But then, we know that we have a lot of other benefits with some of the other SGLT2s, with some of the cardiovascular outcome data. some of the heart failure data, and then safety and kidney disease. So they did look at Brenzavvy. They had, I think, in the 23 trials or whatever that they went through, there was 300 patients with kidney disease or something like that. But it did get approved down to
EGFR
of 30, right?
Yeah. Which is interesting. I guess they had to do that for safety purposes and whatnot. But now that we're like kind of allowing the Jardians and Virgin down to 20, I thought that was kind of interesting. But that's more heart failure and stuff. Obviously, you would lose the efficacy anyway as far as A1C lowering. Right. But it is definitely down to 30 with this one and not lower, at least as of now.
But my biggest question is, does it have the, as far as diabetes goes, does it have the cardiovascular data that the other two big ones do, empagliflozin and canagliflozin? Jardians and
dapagliflozin if you look at the heart failure and stuff.
And looking at heart failure. So
unfortunately, dapagliflozin didn't quite meet anything as far as endpoints that was too exciting.
Yes, turns out there is a little known fourth SGLT2 before this one that nobody ever talks about.
Yeah,
the poor middle child that nobody ever pays attention to.
Right. But yeah, so they already did their cardiovascular, at least their initial one,
cardiovascular.
I thought it was kind of interesting too, because the other ones came out, with their initial data, and then as post-market, which I imagine they would probably do another follow-up maybe. But this one kind of came out, it was at least the top line data was published before the drug, or at least, we couldn't find the actual publication of the entire data set. We found like the abstracts from like where it was presented back in, I think, 2020 for the ADA.
It's a while ago.
And I looked through all the results and stuff are on clinicaltrials.gov, but there's not like at least that we could find. We spent literally 30 minutes looking for this. But it was the publication actually where you could go through everything and the supplemental data and all that. But yeah, one of the studies that they're calling the BEST trial, which is
turns out
a bit of a leap, and they, as they point out, was had modest degrees in systolic blood pressure lowering, and you know what? They were so proud to say non-inferiority for cardiovascular outcomes for MACE. The problem is not.
Which they highlight, of course, that's what they were going for,
right?
Of course,
because that's what the FDA requires.
Right.
But they failed to mention is that it did not meet superiority.
Right.
And so now it's like, well, is this another orforgliflozin?
Right. So a little bit about the BEST trial. It went from 2015 to 2019, 1,700 patients, and then they followed them for a median of 30 months. Patients were 40 years or older with diabetes, A1Cs between 7 and 11. In this study, the EGFR was over 45, so they were excluded if it was under 45. And as far as the comorbidities go, the cardiovascular comorbidities in particular, 63% of the patients had ASCVD. So the majority of the patients, this would be considered secondary prevention for. 14% had a history of heart failure, and then 23% were over 55 years old with at least 2 cardiovascular risk factors. So they'd be considered higher risk from a primary prevention standpoint. But as you go through, you can see in the results that they met their primary endpoint of non-inferiority to the composite of cardiovascular outcomes, but they did not pursue superiority, which means that they knew they weren't going to get it.
Yeah, I mean, unless they're planning just an awesome
reveal
of the new data that they're keeping under wraps. I think there's also it was very few cardiovascular events reported anyway. So placebo and the actual treatment arm wasn't really that different.
And that's one thing with these studies. I'd have to go back and look at all the specifics of IMPA-REG. But what was if you can recall, what was the risk, as far as how many primary, how many secondary prevention they had? Does it mirror this one? Well, I remember that being a topic of conversation in the past.
I have the only one that stands out to me is the Trulicity, the GLP-1 Trulicity data, because they had I think over 70% of people were primary, and that stood out. But I feel like usually it's the majority. I just can't remember to what extent. Right. I think the
usually if you had the majority who already have ASCVD, then they're pretty high risk for a second event, and so that would work in this drug's favor. So they can't use the excuse that it was a lot of primary prevention patients.
Yeah.
Right?
And so, and unfortunately, there was, like you said, 60% of, or more than 60% were secondary. So, that was a little disappointing to see, because I thought maybe we were going to have another good option on our hands for prevention of heart failure and all that good stuff. Right. So maybe more data will come out as time goes on. But definitely, it's one of those. Now I don't know. I haven't seen anything about price, so I don't know. Like that's one thing that the erythrocliflozin, the Steglatro did, was they just made their drug like a couple $100 AWP cheaper, and that was their big claim to fame. And they got a couple Medicaid plans on board and stuff to make that their exclusive preferred agent. But maybe. But then that gets into the whole realm of, should you be able to do that?
Yeah. That whole ethics situation.
That's a good term for it, ethics. I was excited when I saw this, when I read the headline of it got approved, and then quickly became less excited as I read on.
I mean, overall, it's not you wouldn't consider it a bad drug. I mean, it's reasonably safe. They did reference an increased risk for amputation, small digit or whatever. So
there were 23 patients that had amputations, which was statistically significant, higher compared to the placebo arm. Yeah. So it's 8.3% versus 5.1 per events per 1,000 patient years. And so that was kind of interesting that we saw that again, because that's the whole thing with Invokana, that they ended up getting, that box warning got removed. And so kind of this pops up again. So that was kind of interesting. But yeah, they did mention that it was, so 23 patients, so 15 were amputations of the toe and midfoot. And then 8 were amputations above or below the knee. So, again, it's the whole, we've joked about it before, but it's like, it wasn't, I mean, when we see amputation, we're talking about a couple toes. It's like, yeah, but I mean, you're still cutting stuff off.
You're still losing.
Yeah, I feel like that's not ideal in any setting, regardless of the amount.
So apart from that, it's a reasonably safe drug and works about as well as we thought that the other SGLT2s did before we got better data. So it's not a bad drug. It's just we have better things that are like the exact same. So
and then you get the whole like, well, if there are better drugs like Jardiance, or why even bother?
Right.
So I don't know. It's like I said, I was a little bit disappointed with this one, unfortunately. Yeah. But yeah, so the other side effects were the same kind of thing you'd expect to see, and they even mentioned like Fournier's gangrene and stuff like that. But so this one, I'm not sure when it's actually going to be available.
The dosing, I think, is what, 20 milligrams a day?
Yeah, that was interesting because they only had the one dose.
Yeah.
And so they only did the 20 milligram dose is all that got approved. So at least there's no drug titration or whatnot. So that's one thing, I guess, from ease of use standpoint. Say that's us being positive.
We're looking on the bright
side. Look at
us
go. So, anything else with this one, though, for now?
No, I mean, it's out there. Just you just might see it about as much as you do Steglatro, which is not much.
So not a whole lot. Yeah. I will say, too, if for those of you who are, like, wanting some kind of a resource to keep up with new drug approvals, there's several of them out there, but one of the ones that I like that's really easy is drugs.com. You can subscribe, and they have like the regular patient friendly version, and they have like the pro part of their website, which is funny the way they word that, but that has the new drug approvals and stuff that's like in the pipeline. And so they'll send you an email if you subscribe to that. Just give me your email. They'll send you basically an update whenever there's a new drug approved, so you can be right there and whenever new stuff comes out.
You know exactly what you can see, all these cancer drugs approved, and say, I have no idea what that is, and delete it.
Yeah. How dare you?
I actually know a little more about cancer stuff now.
Do you? Nice.
I just, we deal with some stuff. So,
but so that's that one. You want to do the inhaler next?
Yeah, let's talk about the inhaler. So this is not a novel drug. It's just a new combination of two drugs that we had before. And you might could guess why they would combine these, kind of a reference to some things we've been talking about somewhat for the last, two and a half years. Mm-hmm. But there's a new branded combination of albuterol and budesonide called Airsupra that was recently approved for the prevention and treatment of bronchoconstriction to reduce the risk of asthma exacerbations, only in patients 18 and older this was approved for.
Which is weird because that's the approval is 18 because the studies were down to 4. The big wasn't that
this is a press release I'm looking at, but I don't have
the Mandela trial. I think was one of the first big ones, and I believe that one had young patients. I could be totally off on that. I thought they looked at adolescent patients too. Children between 4 and less than 12 years of age only made up of 2.7%. So maybe that's why. Maybe they have to do one that's more
robust.
Yeah. But so they did have some younger patients though. But yeah, so the whole idea here is that we're all used to albuterol. So we know what the data with formoterol and an ICS looks like, and it just so happens to be the budesonide was also the one that's in the most widely used formoterol formulation with Symbicort. But basically they are attaching the ICS to the albuterol now, and then using that as the reliever. So in the study, one of the first ones that got published in 2022 was the Mandela trial, and they were looking at the combination of albuterol plus budesonide at a higher dose, low dose, and then albuterol by itself, while they're in being used only for as needed, like rescue inhaler use.
Yes.
The patients were also on their LABA ICS combination at low, moderate and high doses, and they continued whatever their initial like maintenance therapy was, and just transitioned over to this for the rescue inhaler. So a couple things that's kind of interesting about that is, with the Symbicort, method, one of the big things that we see with that is if you are going to use the formoterol budesonide as the rescue inhaler, they also want that as the controller as well. So the patient's not flipping back and forth between the two inhalers. And I think the idea here is that, if you're already used to using albuterol, now you can just have one that has some anti-inflammatory effects, but still use your same controller inhaler. But then you're right back into the issue of you have 2 inhalers.
Right.
So it's like,
what's the point?
Yeah. I mean, I get the whole, everyone likes albuterol because we're comfortable with albuterol. But I mean, I don't like the fact that you're back to, having one, because I feel like that could easily get, depending, I mean, I think it's going to be in an HFA device, but I feel like that could still get confusing if it's a new inhaler and then they have the, Advair or Brio or something that they're taking on a regular basis. Then I still feel like there's room for getting them confused, and then you have the whole issue with the LABA being used overuse of the LABA.
Right.
So that was the first thing that kind of popped into my head about it. What are your initial thoughts?
I mean, apart from that, it can be reasonably used in the situations you described. It's just like, why not just do the one that doesn't have 2 inhalers? Yeah.
It is kind of interesting.
Yeah. I mean, apart from that, it seems like, it's just 2 drugs we're aware of. We know why that they combined them and they put them into a combination to make it slightly more convenient if you're going to use these 2. Ultimately, it's not like practice changing or anything like that.
Yeah, and they did use 160 micrograms of budesonide and 80 micrograms of budesonide for the low dose, whereas the formoterol ICS, I think it was the SMART trial, I believe, they used 200 milligrams. I think maybe Sigma and SMART, but START, not SMART. The START trial did use 200 micrograms of budesonide, so a little bit higher dose. But in that Mandela trial, they did show that the higher dose was the one that was superior to albuterol alone. Because I don't think there was a significant difference between the lower dose.
Right.
So that kind of makes sense, but I feel like they almost did that in a sense of like it's less overall steroid exposure because we have 160, but we don't have the 200 microgram budesonide in the United States anyway. The Canadian, the turbohaler version of budesonide is what's in, or Symbicort rather, is the 200 microgram version. That's in Canada and other countries.
Another example of them making the inhaler sound cooler than they are.
Right. Turbohaler.
Airsupra. I don't know that's. I don't know.
Yeah, I don't like it.
Airsupra.
Is it going to be an HFA inhaler? Or do they just say inhaled aerosol?
I think it's an aerosol.
But yeah, so that's one thing about with the having to use 2 different drugs.
Meter dose inhaler.
It is okay. So the other thing I'm kind of wondering about that, I don't know that they'll ever. I'm assuming they will never do a head-to-head trial. At least it's sponsored by Big Pharma. Where they're going to take albuterol versus formoterol, and use the same steroid. But my thought is with the formoterol, one of the things that we like about it is that it is still classified as a LABA, even though it has a really quick onset of action like albuterol. So it's almost like with formoterol, you're getting the best parts of the drug, I guess, where you're getting that short onset, just like albuterol, but then you're getting the duration of action like you would with the longer acting. So I don't know. I feel like at least, from what I've seen so far, I kind of would still prefer the Symbicort. I think unless it's just a matter of the patient doesn't like having to take extra puffs of their controller when they're feeling out of breath.
Right.
But I don't know. It's kind of interesting. There's a really good kind of journal club article on the website called rxteach.com. I hadn't heard of them. Had you?
I saw the same thing, but no, I had not heard of it.
Did you see who the author was of the Mandela trial for the journal club? It was Kristen, her maiden name was Ingold. She was on our podcast when she was a resident.
Oh, well, sure.
Yeah, and so I was like, oh, we know her.
Oh, that's amazing.
Yeah, and so I'll link that in there. So
that's hilarious. I saw the same article.
So thanks, Kristen, for giving us we're using your journal club. But good for her for publishing this.
Yeah, that's great.
But she goes through and kind of just gives a summary of the study itself, and then
I think she had a podcast version on there.
Yeah, she does. She does. Yeah. So look at her go. Awesome. And she kind of does a really good breakdown of the primary outcomes and secondary. But they were looking at the primary outcome was basically the decreased, that exacerbation occurring. And then the secondary outcome was the annualized rate of severe asthma exacerbations, like overall, and then the total systemic glucocorticoid exposure for asthma. And they measured it in prednisone equivalents, and then also response at week 24 on the appropriate validated AQ-LQ. So some definitely shows that the albuterol alone was inferior to the high dose budesonide albuterol combo. Side effect wise, basically adverse events, 5.2% of patients in the treatment arm versus 4.5 in the albuterol alone, comparing high dose budesonide to albuterol. So it wasn't like anything too crazy as far as side effects go, which I figured like we kind of expected that, maybe more occurrence of thrush or something like that.
Right.
But definitely not something that I'd be more worried about the additional albuterol doses. But yeah, so I'll link that article in case any of you are wanting to check that out. But so that one's going to be out there, and I don't think for me personally it's going to change much. I probably will still use want my patients on the Symbicort is both the rescue and the maintenance, but
right.
We'll see.
Yeah,
it's going to be interesting.
We will see.
I feel like it'd be a lot easier to sell that one though to people who are really nervous about
making the actual switch.
Yeah, because I do feel like that's still a thing among some providers is they're like, well, put albuterol.
Right, they like to see albuterol on there.
They
That's
do.
a good point. I bet you this will sell.
That's probably. I can't imagine why else they would have pushed this.
Yeah,
it's
not like it's going to be ineffective or anything. Yeah. But I bet you it'll sell for that reason. They see albuterol and they think, rescue.
That's what I always use for that.
Yeah.
So that part of it's probably it's a smart move from a business standpoint.
Right.
But I still wish we could get some kind of head-to-head data with formoterol and albuterol because I feel like formoterol might be a little bit more effective, but who knows?
Yeah.
All right. Last but not least,
it's probably the most notable one.
Or at least the ones that we're going to talk about.
Or at least the ones that we're going to talk about. Probably the most notable, probably the one that you might have already seen in the news a little bit, especially following the last Alzheimer's drug that was approved. But lecanemab is branded as Leqembi, is a new infusion medication to treat early, when I say early, I mean mild Alzheimer's disease. So we talked about this before. I don't know if we did a dedicated episode or not, but we definitely talked fairly extensively about aducanumab, the previous infusion that was had an accelerated approval for Alzheimer's disease.
I think we did a full Alzheimer's disease episode, I believe.
We probably did, and talked about it and took advantage and talked about it then, which, the findings of that were essentially some decrease in beta amyloid plaques, which is the marker that we look at for Alzheimer's disease. But it was very expensive. And then there were significant adverse effects to be concerned about, frequent risk of brain bleed. Not all of it is significant brain bleed, but anytime you hear brain bleed, you get concerned. But definitely a smaller percentage of those were severe and led to death. So because of that, there were a lot of concerns.
And one of the studies, remember, showed efficacy in one didn't. That was the other big controversy.
Even the studies about whether it worked for beta amyloid plaques.
I think it was the Engage and the Emerge trial.
Were controversial, and then there were people resigning from
it was
FDA
like
committees,
a big deal.
It was a whole deal. So this one is not as controversial because, we'll go through it, but it also got a accelerated approval from the FDA. It was approved in 2023. It is a once every 2 week infusion versus aducanumab, which was once every 4 weeks. It's still expensive, estimated at about $26,500 a year. So you could imagine it would be for the insured if the insurance approved it, or for those who could pay. But we'll kind of get into what the study looked like that ended up, one of the studies that looked at it to get it approved. And to me, I'm thinking a lot about the safety aspect, especially because that was such a concern with the aducanumab. But what are these drugs? Like, what do they do? They are a monoclonal antibody, as you might have guessed, that bind with high affinity to amyloid beta soluble protofibrils, which is effectively going to, the idea is for it to decrease the amyloid beta plaques, which we presume, based on information we've been given, that this is going to hopefully delay the progression of Alzheimer's disease. Similar with aducanumab, it's intended, or at least the studies were in patients who were in the early stages of Alzheimer's. And so there is an early onset Alzheimer's disease, and that's why this was confusing me a little bit. But I think when they say early Alzheimer's disease, which is literally in the title of the study, they're talking about early stages. And so like
mild cognitive decline.
Right, mild cognitive decline, but has evidence of beta amyloid plaques.
Yeah, on imaging. Yeah.
So this had... this trial in particular was phase 3, people 50 to 90 years of age who were in this mild cognitive impairment or mild dementia stage of Alzheimer's disease with evidence of amyloid plaques on PET scan, or they could have cerebrospinal fluid testing. They were either given Leqembi or placebo, and then it was going to go for 18 months, a year and a half. And the primary endpoint was to look at a change in the clinical dementia rating sum of boxes score, which is a very odd name for a score. But there's 3 primary, memory tests that would be used and might be used
in a lot of the studies and whatnot.
In a lot of the studies in dementia. This is one. You've probably heard of the MMSE, the mini mental state exam. That's another. And then the MoCA exam is another common one that I've seen more often.
I think isn't one of those two are like you're supposed to like pay some kind of fee to use, right? Because they're copyrighted or something. One of them is
possible.
I can't remember which one it is, but I feel like people do it anyway. But I feel like there's something about one of those that you have
I know our institution uses the MoCA, for example.
So maybe it's the other one. I have to look it up. If only Google was a thing.
The MMSCs are used in like other, cognitive, like other studies, not related to Alzheimer's.
Yeah, I don't know. But so those 3 are the ones that are typically shown up in the studies, though. So
they were looking at the change in baseline of that was the primary endpoint, but they did have a number of secondary endpoints related to the change in amyloid burden on PET scan, and then the score on a number of different Alzheimer's disease rating scales. I'll name them because I think that it's important to have heard what they are. Alzheimer's disease assessment scale, Alzheimer's disease composite score, and Alzheimer's disease cooperative study activities of daily living for mild cognitive impairment score. So these are different things related to cognitive impairment, but also related to activities of daily living. So they actually enrolled a lot of patients, 1,795 patients with Alzheimer's disease. I thought that was a lot.
Yeah.
Split into 2 arms. And the primary outcome, that initial score that we talked about, the mean change of baseline was less, as in they didn't progress as far in the lecanemab group versus placebo, and it was considered statistically significant.
They didn't have cognitive decline as rapidly.
They didn't have as rapid cognitive decline based on that score, and it was statistically significant. So that's primary outcome. But then they say in a sub-study, I didn't look super deep into this, but it says in a sub-study involving 700 of the participants, there was a greater reduction in brain amyloid burden with lecanemab than placebo. I wonder why they have to specify it that way as opposed to this is a secondary outcome. But
was it patients that were considered to have more in this criteria more advanced Alzheimer's versus
possible.
We should have looked into that.
We should have looked into it because my presumption was that it was just maybe they couldn't get PET scans of everybody.
Well, I think that they have to as part of the criteria.
Maybe initially, but maybe they couldn't get adequate follow-up PET scans. I don't know. Maybe not. We should have looked. But that is something
we should have looked.
Something they mentioned.
Missed opportunity for sure.
But what I'm kind of wondering more about is the safety. And so with the
real quick about that, just to throw this out, because you mentioned you slowed the decline and all that. If you read the reporting, they say 27%, compared with placebo, but the absolute difference was 0.45 points on that CDR sum of boxes.
Right.
So there's another article that's like an editorial that's published in Lancet on December 3rd. And basically it's called, if you want to look it up, the lecanemab for Alzheimer's disease, tempering hype and hope. Yeah. And basically just kind of going through that Clarity AD, which is the study Cole's referring to, and just kind of pointing out a couple things about it. But so they mentioned the 27% and that's 0.45 absolute difference in the actual score. But then it kind of goes on and says, that there was a 2019 study suggested that the minimal clinically important difference for CDR sum of boxes was 0.98 for people with mild cognitive impairment and presumed Alzheimer's etiology, and 1.63 points for those with mild Alzheimer's disease. So, and he also points, then I'll bring this up after you mention your adverse effects, but I thought that was kind of interesting that it's it's only approved for patients that already have, mild to, or mild, dysfunction, cognitive dysfunction. And then on top of that, it based on some other schools of thought as far as what a clinically relevant change is, it's not even half of what we would need.
Yeah. And I agree with that. I think there's real questions about whether you can consider it clinically meaningful because the statistical difference does not necessarily suss that out. Though that's interesting, some of the point values they give, because the baseline score on that CDR was 3.2, and so interesting that they would say the decline of 0.98 or 1.3 would be considered, clinically significant.
The CDR was 3?
It says the mean CDR baseline was approximately 3.2 in both groups.
Really? I thought 3 was severe dementia.
That's what it says.
Which one are you on, the actual article itself? Yeah. We'll need to look at that real quick. But go ahead. Sorry.
Yeah. So whatever it is, it's interesting that I'm also interested in how they determine how that is clinically significant. What I'll say is, but it's easy to. I think it is easy to discount the benefit because even they're tempered in their conclusions to say that it was just a moderately less decline in cognitive function over this period of time.
So this is baseline 1.21 versus 1.66 with placebo.
That's what I see for the change in baseline.
Oh, change from baseline. Yeah. Sorry, I'm an idiot. This is the most research we've ever done on the air. Sorry, go ahead. I didn't mean to cut you off.
I think it's easy to look at the difference in question whether it's clinically significant and maybe discount it. But for what I've seen people with ALS pay huge sums of money, even when they didn't necessarily have that much expendable income, to take some of these ALS medications with questionable benefit as well. So I think you would see a fair amount of people ready and willing to use this, even with the moderate potential for benefit. I guess the question just really comes with more, Medicaid Medicare services and whether they're going to cover this from a national standpoint, or other insurance companies that are going to cover this for a large proportion of patients and pay huge amounts of money. They will have to make a determination as to whether it's worth it. But anyways, back to some of the safety. So the most common adverse event was infusion-related reactions, which you would imagine with infusions. But there were some imaging abnormalities that I don't think can be discounted. So some edema in the brain, a little bit of fluid in the brain, and also effusions too. So for the most part, these were considered more mild than with aducanumab at this point. Of course, it's still early. So just kind of hot off the presses, there was a case report of an individual receiving this medication who had multiple cerebral hemorrhages and died, but it was specifically a patient who was having a stroke and was receiving TPA, right? So that's kind of more of a specific instance. So it's not like they were just having hemorrhaging from this medication. They were also receiving TPA for a stroke and it resulted in multiple hemorrhages, but that's pretty recent.
I see what I did. Okay, so just so we're clear, sorry to interrupt you again, but I just don't want to lose this. The CDR sum of boxes is the one that's the 0 to 18 score, and then it's the CDR score that's the global rating. The global version, I guess, is the one that's 0 to 3.
I see.
So because they only went up to 1 on that one, so I was like super confused. So that's why. Okay.
So the sum of boxes was 3.2
yes.
out of 18. So that's how they would consider that mild impairment.
Look at us go. We're learning together as we go.
We're figuring it out.
Sorry, I interrupted you like 15 times this episode. Go ahead.
So basically over 18 months, just going back to those numbers, the lecanemab group went from 3.2 to 4.4, and then the placebo group went from 3.2 to 4.86. So it is a pretty subtle difference. Even just looking at those numbers, obviously you have to go into what they're actually asking and what those things mean. I don't know. It's just a conversation you'd have to have with a patient and see if they're willing to consider this. But if a patient can't afford it or is questioning it or is concerned about the side effects, it's not like you would be keeping them from like a life-changing therapy type of deal.
And that Lancet article, he kind of closes with, and this is, I'm quoting, but a decision is yet to be made on cost, but is likely to be prohibitive for low-income and middle-income countries where most people with dementia live, worldwide statistically. Many health systems lack the infrastructure to enable widespread rollout of lecanemab. The availability of PET imaging to determine treatment eligibility is patchy. Memory clinics will need the personnel to facilitate biweekly intravenous drug infusions, and the capacity for regular MRI scanning to detect ARIA will need to be scaled up. And so the results, he says the results on lecanemab might well pave the way for much needed treatments for Alzheimer's disease, but for now the key public health message for Alzheimer's disease remains that basically laid out in the 2020 Lancet Commission on Dementia Prevention, Intervention and Care. So we're looking for modifiable risk factors for dementia, hypertension, smoking, diabetes, obesity, things like that to maintain brain health. This is not, or at least at this point, we can't say it's a game changer like I think it was kind of being touted initially.
Right. And so those ARIA that you referenced is the amyloid-related imaging abnormalities like edema and effusions, which are the kind of concerning, can be relatively benign, but are kind of the concerning situations. Well, that guy sounds like a pessimist. He does.
But, I mean, I feel like it's also like it's easy in this type of disease state where they've been waiting for so long for them to get some kind of a, game-changing drug that I think people get so excited when they see stuff. Plus, you're getting reports from the company that's making, so of course they're going to hype it up. So I think maybe in this particular case, maybe he's just trying to like calm people down before everybody gets too hyped up about something and not read the data.
No, he's definitely throwing some
shade,
some water on the fire.
I'm going to say somebody didn't get asked to be a speaker for that for that drug company.
No, I mean here's what I would say. I would say that it feels like it's moving at about the same pace as ALS, but it is great to have advancements that show some sort of promise. And even though there are a lot of people who may not be able to practically have the medication, for those that can, it's nice to be from a clinician standpoint to be able to offer something.
Yeah.
To say like, this isn't going to be life-changing, but this might slow the progression some. And to those patients who don't have the means to it, on the other hand, you can say, this would only potentially slow the progression some, and there's some concerns about it. So, it goes both ways, but it's at least nice to have something as opposed to just saying like, we don't have anything that can, remotely make a difference apart from lifestyle changes.
I feel like, the good thing about donepezil, and, in memantine and whatnot is you don't have to get MRI imaging of your brain to make sure there's no issues going on.
Right. And you can still do this along with this.
Yeah, for sure. But I mean, if that's your only option, it's like at least you're not getting scanned all the time.
Right.
So, I agree. And at least there's not as much or nearly as much controversy around this one like there was with the last one.
Right. And I think people have, the companies and the researchers have to take some chances and push some of this stuff to move things forward, to breed other people looking into something that would hopefully be better and then get them out,
One thing, just to kind of throw this in there, we were talking about before we started recording, but it's kind of interesting because they also looked at as like secondary kind of endpoints. They were looking at changes like in the MMSE, for example. And it's just kind of interesting because like when you look at, depending on which study you're looking at, there's not like an agreed upon sort of like, okay, if you have this, from this score to this score, that's mild, this is moderate, this is severe, because essentially with that exam in particular, I think you have to get less than 21 to get into the moderate range. But there's, like if you look at UpToDate, for example, they say 19 to 26 is mild. And then, moderate 10 to 18 is the higher score means you got more right on the exam. But there was plenty of patients that were, not plenty, but there was patients included in this study and its previously approved drug, the adalimumab. What's the, not adalimumab, that's
aducanumab.
Aducanumab, thank you. That had a MMSE of 30, which is the perfect score.
Right.
So it's like, well, those, they may have some imaging, but some beta amyloid plaque on imaging, but they're not cognitively impaired at all according to that test.
Because that is true. So that would make the results of this look a little better if those patients didn't progress as much. But I presume that would be the same with placebo as well. But to that, I suppose, if a patient, unless it was an incidental finding, had a PET scan and found amyloid beta plaques and had gone through this whole process of going to memory care, even though they may have scored a perfect score, clearly there was something that prompted them to seek treatment for it. Mm-hmm. So that they were obviously not at whatever their baseline was previous to that. But you're right, that would be the mildest of the mild, I would suppose, of patients with Alzheimer's disease.
Yeah, I mean, don't get me wrong, the test isn't that intense.
Right.
But I imagine I could score at least a 28.
And I know there is like I know at least on the MoCA, there's some caveats that are made depending on level of education. So like maybe a patient has a high level of education, is able to score really high on those things, but they still, from their baseline, are cognitively impaired,
And there's something like drawing the hands on a clock, I think is the MMSE. I mean, I would be...
Might not be able to do that one.
I was going to say, I know for a fact, because we have a clock in our living room that my wife can literally never read the time on. And I make fun of her all the time, so she'd know it doesn't care. She doesn't care that I'm calling her out. But she's just always, she's like, it doesn't have numbers on it. How much? I give her a hard time all the time. So she has to stare at it for a second to get the time. But
so they're not perfect.
Yeah, no, by no means.
Yeah.
So it'd be interesting to see, and at least there some kind of progress, because it's been a long time.
I do want to say that we are in no way Alzheimer's disease or memory experts. We're just opining on our opinions here.
Expert is a word we use very lightly on this show. We're not. I would be hard pressed to say I'm an expert on much of anything, but
that's why we saved this one for last.
There we go. Yeah. But I did like our roundtable discussion version of going through that, though, as opposed to like having any sort of facts in front of us. We just kind of
figuring out as we go.
Just sort of talking about the drug. We should do a whole episode and just invite people who want to join. We'll just record that, see if it doesn't get out of hand.
Yeah, just tell everybody not to look into anything beforehand.
Yeah, and just see what happens. We'll just talk about stuff.
Just figure it out as we go on live.
So hope that was somewhat helpful to go through. And I will mention too, just because I don't want to have anybody calls out for not being thorough, but there was an extended release injectable version of risperidone that was approved on January 13th, approved for schizophrenia and bipolar disorder.
I did see that.
So biweekly injection for risperidone called Rykindo. So just we did see that one as well. We just figured that the risperidone wasn't as exciting to talk about since we're probably all familiar with at least the active ingredient.
And we have other, we've had other long-acting injectable antipsychotics like Invega and stuff like that. So not super exciting.
Yeah, especially bi-weekly. I'm like,
Do we have the second gen long-acting injectables though?
Yeah, well, no, that is second gen.
It's second
but
gen.
I think I can't remember what the Invega. I can't remember what that one's the 3 month whatever. But they have the 6 month Invega now, I believe. So it's like they got. I mean, if I have to go twice a month versus once every 6 months, it's gonna be hard pressed.
Yeah.
So I don't know, but yeah, that one got approved too. So and we're not even through the first month. We already got some new drugs.
New drugs.
I like it. It's gonna be a good year
time to be in pharma, I guess.
Yeah,
not necessarily pharmacy,
and having a
pharma.
podcast because now we got stuff to talk about again.
We do.
Perfect. So thank you guys so much for listening. Hope that was helpful and not too scatterbrained, since that was even worse than our normal shenanigans. But thank you guys for listening. And if you have any questions, comments, we'd love to hear them. Just shoot us an email. They'll be in the show notes. And if you want more structured versions of lecture style topics, then check out Patreon, which is also in the show notes, patreon.com/coreconsultrx. And I have all my the pharmacotherapy lectures that I do for like my PA students and whatnot. I have them kind of broken down into small bite size, usually 20 to 40 minute chunks. So I don't know, depending on which version of bite size is, I guess. But they're much more structured. You get access to the PowerPoints and things like that. So check that out if you want to go through any of that stuff. There's 4 new diabetes lectures on there. There's a smoking cessation that's actually getting uploaded tonight. So definitely keep adding to that stuff every month and check it out. It's probably the cheapest pharmacotherapy review section on the planet, I gotta say. And so check that out. That helps us out as well. And besides all that, though, we look forward to hearing from you guys if you have anything to say. And also really appreciate you guys still listening to us after all this time. And we'll catch you guys in the next one.